All right, good morning, everyone. We're going to go ahead and get started. Thank you all for being here this morning and joining us on today's Opioid Summit. We are pleased to have you all here. We're also so pleased to be able to have this event, and I want to say a big thank you to our Florida Department of Children and Families for the opportunity to present this information and to bring us all together today. So it is my great pleasure and honor to introduce to you the Secretary of the Department of Children and Families, Ms. Taylor Hatch. And so Secretary Hatch is with us today, and she's going to start us off with some comments here. Again, what a very timely and important topic to talk about older adults and seniors and opioids, stimulants, and drug abuse, because this is a population that we don't always focus on. And so they certainly have needs, and we're very, very glad to be able to share some information with you today. So at this point, I'm going to turn it over to Secretary Hatch.
Thank you so much, Melanie. I'm so grateful for your leadership and the introduction. So good morning, everyone. My name is Taylor Hatch, and I have the absolute pleasure of serving as the Secretary for the Florida Department of Children and Families. Thank you again for having me here today as a part of the Opioid Forum. Florida, like much of the nation, is no stranger to the opioid epidemic. But in Florida, we have an incredible turnaround story to tell, thanks to the leadership of our great governor and partners in the Florida legislature and every single one of you. Many of you here today, you can tell this story well because you have walked it. You have shared and/or you have heard the personal stories, shared your research, shared your passion, your wisdom, your best practices, and your unrelenting dedication to unite around our fellow Floridians to provide the right supports at the right time in the fight against opioid misuse, supporting individuals every single step along the way. As a result, the data affirms that we are on the right track. Opioid-involved EMS responses and emergency department visits are down compared to 2020. And deaths caused by opioids have decreased by 11%. That's 6,157 in the year 2022, down to 5,476 in 2023. These data points are more than just numbers. They reflect lives saved, families preserved, and communities that are healing. Going back to where we all started, as you all know, Florida was awarded the first state opioid response grant in 2018 as a part of the nation's initial response to address this epidemic. Since that time, efforts from this grant have been dynamic and they have been evolving. From expanding access to prevention, treatment, and recovery supports to newer efforts that more specifically have included expanding telehealth in rural areas, funding recovery community organizations, and increasing access to life-saving medications. An example of this can be found in recovery homes, which we all know are so critical for not just the individual that is contending with addiction, but for their family as well. Together, Florida has been able to support the establishment of 48 new recovery homes, bringing the total state opioid response funded homes to 228. Providing 2,035 beds to men and women, with homes available to serve men with children and women with children. Also important to highlight is the distribution of additional naloxone kits. A total of more than 6,888 naloxone kits were distributed through 484 distributors. To put this into context, each one of those kits represents an opportunity to reverse course in a life of a human being. The state's opioid response has also supported initiatives like bridge programs that operate in hospitals and jails, connecting individuals with opioid use disorders to local medication-assisted treatment providers, delivering greater access in communities all across Florida. To illuminate this strategy a bit further, during fiscal year 2024-25, there were 10,889 individuals screened for medication-assisted treatment as they passed through emergency departments and 2,025 individuals screened in a jail setting. This led to approximately 28% of hospital-initiated referrals enrolling in services for treatment and 73% of jail-initiated referrals enrolled. As we continue to evolve, building off of the investments that have already been made, listening to those with lived experience, and using data to guide investments in the future, what remains unchanged is our understanding that prevention, immediate response, and lifelong recovery isn't just about treating the symptoms of opioid use disorder, but addressing all of the factors that contribute to it and supporting all of those that are impacted by it. Addiction is not just a medical issue. It's emotional, psychological, and profoundly social. It impacts not just the user, but also that person's mother, that person's father, that person's sister, brother, or child, or even friend. In recovery, we all know, is not a straight line. It is a journey that demands compassion, a journey that demands patience, grit, and the right supports, connection, and hope. Building on models and beliefs like those behind the Coordinated Opioid Response Network, which in plain language is a team approach utilizing a multitude of different pathways, but that respond consistently with a very specific mindset, turning moments of crisis into opportunities for healing, building trust, reducing stigma, and most importantly, it gives people a real chance at recovery. Nearly 4 years ago, the state, in partnership with community leaders, organizations, stakeholders, many of you in this room, launched the development of the core network. It began with just 12 pilot counties. Fast forward to today, I am so proud to say that by the end of this fiscal year, all 67 counties across the state will be a part of this transformative initiative. The impact has been nothing short of remarkable. In fiscal year 2024 to 2025 alone, core emergency medical services responded to over 200,000 substance use disorder cases, which translates, again, to opportunities to administer life-saving naloxone and safely transporting of people to emergency departments or clinics. Beyond emergency response, our partners across the core network provided services to more than 44,000 individuals battling substance use disorders. Of those, more than 23,000 were living with opioid use disorder and nearly 16,000 received Medicaid-assisted treatment, a critical step towards recovery. These numbers reflect a growing movement of care, coordination, and compassion. Medication-assisted treatment gives us the tools. Integrated care gives us the strategy, and recognizing the needs for Floridians, especially our vulnerable populations, gives us the humanity. Let's continue to build a system where recovery is not just possible, but it's expected. The opioid epidemic demands urgency, it demands innovation, and it demands empathy. The state opioid grant gives us the resources to meet the needs of today as well as tomorrow. As we look to the future, I know through partnership and through leadership, our state will continue to lead when it comes to providing real and meaningful supports that encourage recovery and that encourage grit. The opioid epidemic doesn't care who you are. That's why I leave you, each of you, with this charge. We need all of you, your bold and your brave voices. We need your data, and we need your shared commitment to continue to enhance our unified efforts to serve the people fighting with addiction through a multitude of strategies. And also the mother that spends many sleepless nights worrying about and fighting for her child's recovery. The sister who wants to help but doesn't quite know how. The young child impacted that is struggling to cope and is now struggling academically. And the friend that wants to say no, but also wants to fit in. Thank you so much for the work that you do every single day, for your partnership, and again, continuing to join us in going all in. Thank you.
All right. Thank you so much, Secretary Hatch, and we certainly appreciate your leadership and the efforts of your team at the department to make recovery possible in the state of Florida, and for all the work that you do on behalf of mental health and substance use. So again, thank you so much. All right, moving on to one of the reasons why you all are here. It is my pleasure to be able to introduce to you Dr. Peter Delany, which I hope I have his name right, because Delany, we're in the South, we say Delany. We don't. Anyway, he has had an outstanding career with the U.S. Public Health Service, retiring as a Rear Admiral. Along the way, served as Assistant Surgeon General. He's also been with the National Institute on Drug Abuse, the Substance Abuse and Mental Health Services Administration, or SAMHSA, the National Institute on Alcohol Abuse and Alcoholism, and the White House Office of National Drug Control Policy. He has been key in developing and implementing policy, funding initiatives across the nation in our space for the last couple decades. And I'm not trying to age you over here. I'm just saying he has had a distinguished career, and we're so thankful for that. He is now an associate research professor at the Catholic University of America, and he is in the National Catholic School of Social Service that is there. And so we are absolutely so pleased today to have Dr. Delany with us and to share his insights and overview as we really look to the work that has to be done to address our seniors and this population that are as vulnerable as our youth and adolescents, and who have long been overlooked in terms of substance use. And so we are just very grateful to have him here today. And without further ado, I'm going to turn the podium over to you. Thank you.
Brian, is the mic on? You can hear me now. All right, so I'm coming down there. I'm coming.
I'm gonna wait.
Thank you. I would like a number. Let's go with both. So today what I'm going to try to do is frame a little bit more from a national perspective about the issues, as well as some of the training needs that I think need to be done. One of the things I do at Catholic is I run the community-based integrated substance abuse training program, where we focus on people who are postmasters and we're trying to get trained up, because the reality is, when I went through school, when I did my master's and doctorate, there was nothing about substance use. The substance abuse training I got was when I was in my field placement. So what I'm going to do today is talk a little bit about framing the issue and talk about some of the training needs. This is interactive. I'm going to pose a few questions for you to think about while I do it. And then my other Vanna White, Diana, will be wandering around with the mic, putting it in your face so you can maybe come up with what's going on in your neck of the woods. So first of all, how many of you are 65? 2. All right. Well, that's me and you. We can talk later. How many of you have family members that are 65 or older? Okay, so, I just entered the 65 group, and this is near and dear to my heart. How many of you have family members who have substance use problems? Okay. Which may explain why a lot of you are in the field. So one of the things that it really frames this issue is that this is an aging population. It's what we call the invisible epidemic. There are unique vulnerabilities. Most of us who are older already on a number of medications, blood pressure, cardiac stuff, everything. And then there's also comorbidities. Many of the people we're working with have diabetes. They have other health problems. There's stigma. It's especially difficult for older people. It's difficult for everybody, but for older people, it is really difficult to address, to be able to go into treatment and ask for help. There is also a underdiagnosis. One of the biggest things we have with the people that we train is they don't ask, tell me about your substance abuse, or tell me about your drug use, tell me about any alcohol use. I think it's because they were never trained to ask a question. So the other thing has to do with the social determinants of health. So we're talking about a group tends to be more isolated because they have health problems, because their friendship group is falling away. There's housing issues. There's transportation issues. There are income issues. The transportation, when I worked in Montgomery County in Maryland, people had to take 2 or 3 buses to get to the treatment program. That's difficult enough for a person who's pretty able, but for people who are not able, that's really a pain, and it's really expensive to take cabs. So why training matters and why I do this now for a living. Providers across care settings may be insufficiently prepared to address opioid issues and other substance use, especially among older adults. There's a need for an integrative, team-based, senior-sensitive approach. And my goal in the presentation is to highlight some of the trends, treatments, and workforce needs. So, here's the first thing I want you to think about, then I'll present some of the data, again, mostly from a national perspective. What trends or challenges have you noticed around substance use among older adults in your patients, clients, or community? What trends in alcohol, opioid, or cannabis use are you noticing in the older adults you work with? I was just talking to someone a little while ago, and I can't pronounce his name again, Dr. Stavros? Huh? Dr. Hahn, sorry. You look like a Stavros. Okay, 65, the brain goes down. One of the things that when I was at the Substance Use Mental Health Services Administration, we collected all the data on mental health and substance use in the country. And people, when I was there, said, wow, 40-year-old, man, their drug use is going up. And it happened again at 50, and now it's happening at 60. Many of these people never stopped. The difference is, and Dr. Hunt will probably be able to talk about this a little bit more, difference is that they're getting into other drugs that they weren't having. You know, the biggest issue when I was in the service was cannabis and alcohol use was going up, but it was pretty much stable from other. But now cannabis is also laced with fentanyl and other drugs. So this is kind of a busy slide, but nationally, if you look at it, there's a stable or slight increase in alcohol use among adults 65 or older. One of the key things that we're finding, though, is that there's an increase in binge drinking over the past decade. Cannabis use in the past year, which is what we tend to measure on, it's a sharp increase over the past decade. Again, what doesn't get noted is that it probably didn't get noticed, but it's pretty much, if you go back each 10 years, it was going up. Prescription drug misuse, we have done much better as a country in dealing with this. It's stable, but it still remains concerning, especially among older adults. Alcohol use disorders is about 1%, which is stable, and illicit substance use or illicit drug use is about 0.5%, and that's pretty stable. What is really concerning is that there is a rapid increase in overdose deaths among adults 65 and older, especially with fentanyl. And one of the things I try to figure out is how many of these were related to polydrug use, like were they smoking marijuana, which is often laced. And then alcohol use, alcohol-related mortality as well is a steady increase. And one of the things, it's important to be focusing on opioid because it's an talked about issue, but it's also important to talk about the other drugs of abuse that people are using, especially at this age. So the trends in drug use, prescription misuse, and older adults. So older adults are more likely to prescribe opioids for chronic pain. Even though prescribing has declined, it still remains pretty high in this group. Also, polypharmacy increases the risk of overdose adverse reactions. Misuse and opioid use disorder, about 1% in the past year misuse. It's likely very much underreported. As seniors entering treatment for OUD is increasing, and that's probably reflecting the baby boomer cohort. The question is, as we think about it, are those treatment centers or treatment programs or primary care settings, are they ready to address the seniors? And the misuse of painkillers and anti-anxiety meds is still a growing concern among practitioners. In context, 1 in 8 adults 60 plus used illicit drugs in the past year. And drug overdose deaths in the adults 65 plus rose 11.4%. That's according to CDC. And then I noted that the Florida overdose death rate for 55 and over nearly tripled between 99 and 210. And the secretary's words talked about that's coming down, and that's terrific. Whoop, went the wrong way. I just turned it off. Let's try that again. All right. So key national trends: rising prevalence in the number of drinkers and monthly drinker prevalence. Alcohol-related days, 72% increase in alcohol-related deaths through 2019. And then alcohol-induced liver disease across the country is about 91% since 2010. And then binge drinking, again, 11.4% of adults 65 and older reported binge drinking. 4.8% met the criteria for alcohol use disorder. And then about 2 to 10% of seniors abuse alcohol on any given day. So takeaway, 67,000 overdose deaths among adults 65 and older in the U.S. The mortality rate then is, the way we calculate it, is 12 per 100,000, which is up from 3 in 100,000 in 2000. And the primary drivers are still synthetic opioids, prescription opioids, and benzodiazepines. And the death rates across the country continue to rise. And that's provisional data. I haven't seen the new mortality data. I had a hard time getting that data out from CDC. So here's just a quick graphic. The national levels in terms of increase in monthly drinkers and increase in daily drinkers are up. In Florida, the alcohol-related deaths and alcohol-induced liver disease are up related to 24. And that doesn't matter, by the way, if the use is going down, because they didn't necessarily stop drinking and they still have serious comorbidities that you're working with. So the trends in overdose deaths, I'm going to have to configure this because I only have to 2010, so the secretary's going to have to give me some new numbers if I come back. But it doesn't matter whether you're in Florida or in national, it's going up. So the key takeaways is alcohol and cannabis use is still rising. And when I started in 1982, cannabis was like, low percentage. Now it's this huge percentage, and we're seeing a number of people with psychotic responses, especially young kids. But I'm concerned that we're going to start seeing some psychotic responses from older adults as well. And the opioid-related harms that we think about is the drug overdose deaths in 65 rose by 11.4% between 22 and 23. Again, I don't have any more recent data from Florida, so we'll just kind of drop that until we get some more data. But the biggest issue is that the level of prescription misuse and polypharmacy misuse are really problematic in this group. So the key issue for people working with adults 65 and older is that it's no longer rare to have an overdose death. And that seniors entering treatment for overdose or opioid use disorder are increasing. And that also is the fentanyl. But the social and health risks, which the secretary talked about, are really key. The social determinants of health. Also depression, chronic illness, and physiological changes increase the problems with this population. I'm going to hold off on that. What I do want to do is go back to my questions. So I'd like you all, this is where my second van is going to wander around. I'd like to hear what trends you're seeing in the patients and families and communities that you work with. Also, I'd like to understand what are the key issues around those people you're working with. So, she's wandering around with Mike. Please do not be shy, because she will pick somebody if you don't offer to talk. There we go. There's my fellow Medicaid person.
Yeah. Hi, everybody. I'm Karen Trapek, the Executive Director of the Volusia Recovery Alliance. We are a recovery community organization that covers Volusia County. And we work closely with our medical examiner, and there's a lot of the biggest overdose death numbers in Volusia County for the past year have been around the 50-year-olds. A lot of it has to do with co-occurring heart disease. So, and a lot of them are stimulant users that it's been laced with fentanyl. And so it's really kind of, he believes that some of it is that it's the stimulants that are causing the heart failure and then the death, coupled with the fentanyl. And so we're seeing, although our overdose deaths went down, it's still too many. We had 229 last year in Volusia County alone. And our work continues. But I also wanted to share that I have chronic pain. I've had chronic pain. That's part of the reason why I use substances. I have 42 years of recovery from substance use disorder. And so I was away in Connecticut and I hit the wall with my chronic pain. And I was like getting very desperate. And pain medicine was starting to look like an option. And only because of my foundation in recovery, I didn't go that path. And so I really hope that we can embrace at some point some alternative medicine, because I went to a naturopath when I was up in Connecticut. I also went in a hyperbaric chamber for one treatment, and it took the edge off the pain. But the biggest thing that I want to share is that they put me on a new eating lifestyle, and I can tell you that my pain has gone down. So, I advocate for a lot of things because of my personal experience with getting into recovery and using for the years that I used. But this is something that I hope we can look at as well, that, maybe there's some funding for some of this other stuff. And I know Senator Wright is a big proponent of hyperbaric oxygen for veterans, but it needs to be talked about more. So I just wanted to share that because I feel like I went through all this stuff within the last month that needs to be shared because it made a difference. Thank you.
Thank you for sharing that.
All right, any more questions? Shirley, or comments? Somebody tell us. Dr. Dybin, you want to give us just a little snippet of what's going on at Hanley?
Sure. I'm John Dybin. I've been working in a residential program for older adults for over 20 years. You're asking about trends that we're seeing. There's so many different things, and I really appreciate you taking on this topic. I can't tell you how many times this is not the topic that people are really interested in, because our older adults are one of those throwaway groups of people. And so it's so important. I'm so glad to see everybody here. I will tell you one of the trends that we're tending to see. So I work in the first residential program for the treatment of older adults with substance use disorders in the country. And, one of the things that we're seeing currently, there are really two things. One is a trend, is we're seeing an increased amount of our patients admitting with some form of dementia. And that's always been, there's always been, for in the 20 some odd years I've been there, well, we'd have a percentage, and people, they're almost always brought in by adult children. The children are saying, hey, Dad is starting to show signs of dementia, and we don't know if this is organic or if it's because he's been drinking a fifth of Jack and having 6 Xanax every day, for 40 years. And historically, it would be a very small proportion. We'd maybe see one patient a month out of 30 or 40. And over the past 2 to 3 years, we've seen that steadily increase. And we're probably about 30% of our patients now we're seeing coming in with some questions of dementia, which then we help to figure out if this is organic or if this is substance-induced. But I'm not sure if that's anything that you're seeing nationally or if there's any correlation between chronic substance use disorders in older adults and increased episodes of dementia.
I can't tell you that I pulled up any data in that area, but I can tell you, I think we're getting better at identifying, because physicians and other practitioners We're getting better at identifying signs of dementia earlier. But that's the right question that the family asks. Is this dementia, or is this alcohol, or is it both? So, I think that that's just something we have to be sensitive to. Again, the challenge, and when I'm training people, the challenge is just to get them to ask questions. If family, you can't ask questions just of the person in front of you. You've got to bring the family in. Often, we're working with faith communities to try to get them involved, and they often see things that other people don't. So that's, and then community centers where like maybe older adults are going to a local community center, they're seeing things. So got to ask the question, and it takes practice. I mean, when I first started out, I was working in an opioid treatment center, and it's like, I was just saying, how do you ask people about their drug use? Well, then the first thing is, well, they're here because they have drug use. So you could start there. Your next question is, tell me a little bit about how much and how often. So it's just getting used to it sometimes and practicing. I also want to address your topic. We do need to explore alternative interventions. I had, when I was in the service, I had a severe neck injury, and I'm using microcurrent every day because of damage to my spine. And thank God they were very good at it. And if I don't do it, because I will tell you I'm a little pain today because I haven't been able to use it yet today, but when I get home tonight, we're going to wrap that little beamer around my neck. But so we have to look at things like microcurrent, hyperbaric chambers, but there's also other alternative therapies. There are natural therapies that we're just not looking at. Meditation, mindfulness, we talk about, but meditation and mindfulness really do help people in terms of not necessarily managing, but focusing so they're not taking pain. Because look, how many of you have been around and you're feeling a little itch? And then you start focusing on it and it gets worse. And it gets worse. It's the same thing with pain. So I meditate, I do mindfulness, but I try to do it in such a way that I'm intentionally not focusing on the pain. So those are things that work, and it works for me. I can only talk about myself. So let's do a little rapid spin through medication first. So the philosophy is that, and by the way, I helped develop the Housing First program with the veterans. So our thing was get them into a stable living situation, then address everything. This is cool. This is a really cool way to go. So you do rapid, low barrier access. So you initiate medication the same day when possible. You minimize waiting lists. You prior authorization and referral delays. No punitive prerequisites. No requirement for detox or counseling before prescribing. That means you have to you have to ask how much they're using, what they're using, because you can't put medication in unless you know what you're doing. So if you give somebody like half of what they're doing, that's probably going to create relapse, or they're going to be double using. Avoid abstinence-only conditions or requiring failure at other treatments. This is really a harm reduction, and along the way, you're working to get them into treatment. And focus on saving lives, then building recovery supports. And I'll talk about that later. The reality that I learned a long time ago is you can't take away a drug without filling that space. Whether it's AA, NA, whatever, family support, community support, you can't take away something unless you have a backup. So, and why it matters in older adults. And I haven't, this is the first time I was delving into the medication first literature. So now it's going to be part of our training program. So thank you. Diana and Eva, thank you. Older adults are just highly vulnerable. We all know that. There's delays that increase overdose. There's hospitalization risk. There's mobility and transportation barriers, which make prerequisites especially burdensome. There's stigma and shame that are amplified in older adults. And low barrier entry reduces drop-off. We want them to stay in treatment. Integration with the whole person care. Stabilization first, support second. Actually, in my mind, that I don't like that. Stabilization first and supports at the same time. And then team-based care. That's something we focus on in what we're doing in the integrative program. Physicians, nurses, pharmacists, social workers, and peer recovery specialists. One of the things we train our providers is that they are all professionals. It's not like a lot of times the integrative teams that I've worked with, peer recovery specialists, like, well, they're kind of throwaways. That's not true. They're key to recovery. And then harm reduction is compatible. Naloxone, safe prescribing, overdose prevention. It's compatible with a medication-first philosophy. All right, so this is another question. So at least 2 of you have to get ready to answer this. I want you to think about when treating substance use in older adults, what have you seen that works? Or what challenges have you faced with prescribing or medication management? And that's not just physicians, that's all allied health providers. So medications for opioid use disorder, buprenorphine, it's safer with comorbidities. Methadone is effective, but there's some regulatory caution, but it's also, I'm not sure that's the best medicine in relation to other polypharmacy. And naltrexone is useful, but there are adherence challenges. And it's not just in older adults, it's adherence challenges across the board. One of the things when I was at NIAAA, and I was running the health service program, is what we saw is naltrexone was used to a point, and then it just flatlined. Antabuse was good to a point, and then it flatlined. Buprenorphine went to a point, and then it just flatlined. So I'm not sure why it doesn't keep using, but that's something to study. Maybe I'll run a study on that. So naltrexone, oral, again, there are potential interactions, and there's a lack of safety data. That's another real problem we have in the world. We're not studying substance use among older adults and all the other issues that are involved. Camprol, careful monitoring of kidney function, especially in older adults. And then Disilform, caution in seniors. There are heightened risks for side effects I found in some of the literature. So clinical considerations for medication provision is that they're polypharmacy and drug interactions. Many of these people are on multiple medications that are illegally prescribed because of health conditions. There's a high overdose risk. Team-based and integrative care is really required to really help in this situation. And there's a need for medication reconciliation. You know, most pharmacies, if you get prescribed a medication and they have all your other pharmacy medication, it might bring up, that's it. But I cannot tell you the number of times when I've had a client who goes to a doctor and gets prescribed something and it totally interacts with their other medications and nobody checked. Some of them, they go talk to their sponsor and they go, is this safe? And sometimes their sponsors are pretty sophisticated. Although a lot of sponsors like, no, you don't need any medication. I'm like, get a different AA group. And then remember, this is a slower metabolism. God, I know that. You know, I used to be trim and thin, and you know, I'm older. And there's a lot of sensitivity when you get older. All right. I also want you to think about beyond medication. Well, let me go back to my questions. All right. So at least 2 people have to stand up and answer, what have you seen that works, or what challenges have you faced? By the way, you get a gold star if you answer a question.
Good morning, everyone. My name is Jennifer Robinson. I'm with DCF in the Southeast regions. And some of the things that I see work, because I had sometimes dealt with older adults. I myself am in recovery with over 18 years clean and sober. But some of the things that I've seen that would help older adults is slower pace and shorter sessions, if that. Also, to be in a space not with a younger crowd, just someplace where they feel like they're respected and that they feel like their needs have been met. I wrote some stuff down, and just focus and prioritize mobility that with them, and have that independence plan that they need. You know, that also issues if they have chronic critical issues, and also mental health and the OUD issues. So that's what I seen that helps, and what they all ask about, because a lot of them don't want to be in a room with younger peers because they feel uncomfortable. They feel like it's too fast paced, and they don't want to sit in sessions too long. Mm-hmm. So that's what I see. Thank you.
Yeah, I'm going to cover that a little bit later. But also, what happens too is the same thing as they start to compare out because they don't have the same life history. Doesn't mean that they haven't got the same problems, but they don't have the same life history. It's very easy to compare out. Well, I don't have that problem. So anyway, Hi, my name is William Atkinson. I'm a person in long-term recovery. I'm the executive director of the Recovery Epicenter Foundation. We're an RCO out in Pinellas County.
You asked a very loaded question, and so I apologize for my answer.
I won't be offended.
Okay, cool. All right. Medication management suffers from the same problem as active use, which is that it develops a tolerance within the body. And inevitably, the scratch that you're trying to itch with it is no longer effective. And with older populations who have been through that type of cycle multiple times, oftentimes feel, and this is what they've expressed to me, is that the withdrawals are not worth the payoff. And so what has been challenging is helping individuals like the young lady mentioned with chronic issues. The older the human body gets, the less it's able to be self-supporting. And unfortunately, if they have long-term substance use disorders, the less support they have from family, social structures, et cetera, because they've burned through those type of opportunities. So we find, actually, at our peer respite centers, the most difficult people to place are the elderly because of their lack of long-term support. And so, like she shared, addressing what they feel is important is needed, and I don't believe yet we have established correct funding sources to be able to help people the way that they are asking to be helped. Primarily due to stigma and, hey, we gave you all these other opportunities before and now your body doesn't work, and so at which point we really can't give you any more help. And it's a very sad type of circumstance because I know that everyone here in this room wants to provide that help. In the end, we're held to the levers of where we're allowed to. And so that becomes a challenge.
Thank you. Gee, I thought I was going to be offended. Sorry. But the thing that you noted, I think, is so critical is asking them what they need. So some of them aren't ready. I mean, I can't tell you the number of. Again, I used to work with the homeless population. They did care. What was the purpose of getting methadone if you have no place to live and you're still living on the streets and you can't get to treatment on? So first thing was finding housing. So again, but here's the other thing, every client is so unique, even though they have some of the same background, right? So how often do we categorize them and go, oh, they need this? The second job I took was at a mental health, co-occurring program, and they had this treatment plan. It was categorized by the state and we had to follow it, but often it didn't make any sense because they didn't all fit that need. So we also need the flexibility to develop treatment plans that fit the needs of the people or the person in front of us. And it's also, here's the other thing, and the number one variable in getting people, whatever age, to get into treatment and stay in treatment and stay long enough is your therapeutic relationship with them. It explains between 70 to 80% of people being in recovery and staying in recovery. And that is just so critical. But your comment's well taken. We need to know more about what works and need to know how we can flex around the needs of each individual rather than just the population. Yes.
Okay, hi. My name is Judy Charleston, and I work at a building where it's residential, where we work with clients that has mental health and substance use. So majority of my clients are over 50. And so that was the method they were going off of, housing first, because they came from being homeless, and those were the idea to get them assistance with substance use. Now, the problem we encounter is they have the housing and they have the income because of SSI and things like that, but they're not interested in stopping the drug usage, you know what I'm saying? So they are comfortable with doing the drugs in their home, and they're comfortable with continue to do it. Even we're trying to assist them with the help, but they don't want any help with that. So that's what we find challenging. So when they're doing this mainly, the majority is crack, and they're fine with it because they have housing. So they don't have any stresses, so they're fine with just doing the drugs. So we did the housing first, but it's no consequences or anything to force them to be in the treatment or participate or anything like that. So we find it challenging with that aspect because that's what they're doing. They'll get their check, and then this is where it's at because you're on a certain income. You know, the property is paying a certain amount. What the program is paying a certain amount towards their rent and stuff like that. So they have all this money left to enjoy and live their best life. And then we're dealing with challenges of them once they're doing the drugs, they're more angry. And so we deal with a lot of angry people, even though they're doing what they want to do. It's a lot of hostility, a lot of angry things going on, but they're not interested in getting the services. Like we had a service plan put together, goals and things like that to help them with the treatment. They're not interested in getting any other treatment.
Sucks, doesn't it? I don't have a great answer for you. Again, it's you all know it's building that therapeutic relationship, and a lot of helping people get into treatment is is thinking about what goals they want to achieve first, and then I use my primary intervention with substance abusers. Well, I'm trained as a cognitive behavioral therapist and that ilk, but my primary intervention is really using the technical skill of motivational interviewing just to build that rapport, and just to if you were going to stop, what would it look like? I use the miracle question a lot. I was trained in task-centered and problem-solving theory. So if you woke up in the morning and all of a sudden things were better, what did it look like for you? And helping them get hope and envision. So I can't give you a great answer, but it is something I've struggled with. Jesse Milby ran a program in University of Alabama that I was his project officer, and he had this program called Bad Boy Builders, where people were brought in. They helped rehab a small apartment that became theirs, and then they worked with Bad Boy Builders, and then they were required to participate in a recovery program. And as long as they stayed clean, they got training. They got training to become an electrician, a builder, whatever. But if they relapsed, he said, okay, you got to go out of the house for 2 weeks, get clean again, and then you can come back. So it wasn't like get thrown out forever, but you could come back. And if you look at Jesse Milby's research, it's pretty good. Okay. One more, yeah.
Hi, my name is Amber Williams, and I'm with DCF. I'm also a person in long-term recovery, and I've just got a personal experience with an older individual who happened to be my father-in-law. And because of my experience, me and my husband in recovery, one of the things that my father-in-law could not see is that this was the same. And when you were talking about, you really hit something for me when you were talking about they don't see the same. So my father-in-law, not in services for any mental health disorder, not in services for anything, but he had chronic pain. And one of the things that happened is he started searching for. So he was taking his friend's medication. And even though I would try to give some education about it, it fell on deaf ears because of my experience. So one of the things that I think that would be extraordinarily helpful is when the information can come from their doctor. And, because he respected his doctor. He respected what his doctor said. His doctor gave him this medication. He trusted him. However, what happened was eventually they found out when he started asking for more pain medication, they gave him muscle relaxers. They gave him benzodiazepines. He eventually went into the hospital because he had a bad reaction, and he had stage 4 cancer that had metastasized to his bone. And so for me, one of the things is if they had done a little more investigation in that, and, giving that education on what this medication can do. So that I think that there's a piece that is missing in that there's a whole part of people that we're missing that are not involved in other services. So I think that our country doctors need to be educated more on what happens when a person is taking this much medication.
Absolutely. I mean, they're part of the team. They should be part of the team. And we are training more physicians to know about opioids and other drugs of abuse. But still, a lot of professions, I guess ours included, at least in social work, we try to reduce the symptoms rather than address the back of the issue. So I appreciate what you're saying. It is a very tough thing, and it really behooves all of us to start working critically with our partners, the doctors, the nurses, other practitioners across the board, physical therapists, by the way, things like that. Again, it's a question of starting to ask the questions with a level of respect and dignity, especially among the older population, because as you noted, they're kind of a throwaway population, as are the adolescents, or adolescents are kind of a non-wanted presence. And I know I grew up, I brought up 2 adolescents. So, I know times I wanted to say some things. All right. So, sure.
As I'm listening, my name's Carrie Lester. I am with Thrive IRC in Indian River County. And I'm thinking on the prevention side of things because our organization does prevention and recovery. And so I just wanted to throw out that we've started doing wellness initiative for senior education. And I think, yes, we're talking about like us and the professionals being trained, being comfortable with asking the questions, but we're also in our organization and community empowering our seniors to ask questions. There's also a prevention campaign called Use Only as Directed, where we can empower people in the community to advocate for themselves with their physicians. And so I think it goes both ways. And obviously we're here on that recovery focus, but I just wanted to throw out that there are prevention efforts we can consider. And lastly, I'm honing in on that 55 plus population. So I've been at a lot of doctors recently, and I have noticed their discomfort level in asking me about my substance use. Actually, Friday one gave me the leading question of, you don't smoke or anything, do you? So,
No, I don't smoke.
So I think it's just really important too, again, that physician training as I watch the level of discomfort and the conversations I've had when I talk about the work I do, so little understanding and education and the medical professionals I've seen recently around substance use.
Okay. Thank you. Yeah, I didn't mean to blow off prevention. I think it's a lot cheaper at the front end. Diana, when do I need to stop? Because I know I'm burning through time. Oh. I got to look. I can speed through this in 10. Yeah, I think the training is so critical. For all of it. I mean, again, when I get my care at Walter Reed, because I'm retired service, and every time I check in, they do a PHQ-9, they do a GAD-7, they ask about my drug use, they ask me about alcohol use, and they ask about my smoking every time. And then when I go in to see my physician, she goes over it with me. It's required, So I'm very comfortable talking about that. They ask me about my family, by the way. I have 2 family members in recovery. They ask me about my family, what's going on, because they want to know the history. So it is a matter of training. And I have actually given the training at Walter Reed, so I'm pretty sure that they're getting better at it. But we need to train everybody, not just physicians, but everybody. Did I do that? Yeah, I went back to the questions. So for this section, I want you to think about beyond medications, what counseling supports or community resources have worked best for older adults in your experience. We're already answering some of those questions. And what gaps in services or training needs do you see in your own setting when it comes to older adults? By the way, I just want to say, if there's questions if you want me to pay attention to while we're going through, just let me know. Also, I've given Diana my slides. She's going to release them later. My email is on that. If you have questions or you want to follow up, please feel free to call me. No, actually, email me. I want to answer my phone. So I'd like you to think about that. What supports work best? What gaps do you see? I think we've already talked about a bunch of them, but we'll go through it. So I'm going to kind of talk a little bit about the types of behavioral approaches that the data supports. And you talked about pacing, weren't you? Back there, slower pace or shorter sessions. Cognitive behavioral therapy works really well to some extent, but it's got to be adapted to pacing. It has to use a lot of repetition. And we found that using memory supports is really critical. But when you do the pacing, you're right, they can't do 45, 50-minute sessions. They can't do hour-and-a-half long groups. But you're also right, they have to match what's going on. I do a lot of just psychoeducation groups when I was doing that. And again, we did group them by age. Adolescents, which always had 2 or 3 therapists in it, because that's just survival mode for some of us. We did young adults, or what we call emerging adults now, because apparently we don't let them get out of the house soon. And then we had, people 30 to, 40 or 45, and then we had older adults. So we did put them in groups that were like, but we changed the approach. Even though we cover the same material, we changed the approach. But psychoeducation was key to all of what we did. And we used CBT to kind of help do that. But with older adults, helping build in memory supports, especially if they're early in recovery, because they're still, detox takes a lot longer than for younger people, but it also takes a long time. I mean, what does AA say? The first 3, 6, 9, and 12 months of those periods are hard because we've now known that physiologically there are some big changes that go on in the body around that time. It's probably slower for older adults. I use with almost all of my people a life review and a meaning making. So I try to integrate past experiences of treatment. I try to talk about what's been good in their life, what works in their life when they've had a challenge. So bringing that up, letting them teach you about what works for them. But it also, stuff has to be concrete. It has to be problem-focused strategies. Sleep hygiene, pain management, daily routines. How many of them have disrupted their daily routines completely? How many of them actually sleep? Because a lot of these medications just screw with your sleep patterns. The pain management, that's come up a bunch of times. We can use alternative things to pain manage. Do you have a question? Okay. You don't have to wait till a question and answer time. You just kind of bring it up.
Yeah, I was just going to kind of refer to what you had mentioned on your question slides too, but to kind of integrate with this, meaning making for sure, with some of them especially being younger than these older clients, hits harder sometimes for them to accept, especially if they've been in treatment for a while, accept what you have to say. But showing them they can also be mentors, showing them they can be peers. I've seen that work with a lot of them. Because otherwise, what's the point? I have some clients that are in their 60s and 70s, and they're at this point, I want to do what I want to do. They may have come to treatment for treatment, but at a certain point, when they fail, especially, they get frustrated with that. So I did see a big improvement in that. And what I've seen as on the negative side is a higher reliance on alcohol as they've gotten older. Multiple medications, nothing's working. It is affecting their sleep. Alcohol works. I'm not doing heroin. They would tell me, Stanley, I'm not doing heroin. I'm not doing fentanyl. It's just alcohol. So I've seen a huge increase in that with my clients in that age group.
Yeah. I mean, they'll find alternatives if you're not helping them the way they need sometimes. But that's a really cool program. The idea is like pairing them with younger people, like a sponsorship. So people who've been in treatment longer, who are doing pretty well, might help younger people who are early in their treatment phase, kind of like a recovery sponsor. That's pretty cool. Actually, that's kind of where a lot of the peer recovery specialists are very helpful too, is because many of them have been in recovery for a while and then can help them with the navigating the treatment, but they can also help them navigate recovery. Yeah. So I'm going to suggest one thing that when I train some agencies, one of the things that I found is, some of the guilds, I'm in the social work guild, there's the psychologist guild, there's the counselor guild, there's the LPC guild. Some of them, and my profession in general is bad about this, are really terrified of peer recovery specialists because, well, that's our job. Well, redefine your job, kids, and find out what works. You have to be a team. These are people that need multiple different intervention things. And so I think what we need to do as allied health professionals is think about ourselves is we bring something to the table, and we should be so blessed that other people are willing to bring things to the table to help us with what we do. It is a challenge. I have to get over myself every couple of days, guys, because I keep remembering, I screw up a lot and I need extra help myself. So somebody else, I go with those first three things almost every day when I'm treating a client. I can't, somebody else can. Maybe I'll let them help me. So you had a question, Eric? Are you going to offend me again? Okay. It takes a lot to offend me, so, So
I'm going to do my best not to. And I do apologize. I just want to illustrate that we discuss a lot about peers in the field these days. The way in which we are utilizing lived experience, which lived experience is super important, whether it's from clinical all the way down to entry level. But we keep talking about peers in controlled settings, and what you just described of they're taking my job, that's my role. Clinical practices have a time frame attached to them. It's one of the disappointing aspects of our existing substance use disorder field is that somebody might get 30 days, 60 days, 6 months, a year, but then afterwards they're no longer able to connect with the clinical component that helped them get to that place, because clinical stabilization is very important. The benefit of peers is that they don't have those barriers. So when we're referring to peers, but we're mentioning them in controlled settings, we're actually talking about behavioral health techs and case managers with lived experience. Peers exist outside of that entire structure. Mm-hmm. And so if a peer is in any way taking a clinician's job, that's a huge problem. Not only because the peer isn't qualified to do that, but because the entire setting is just not appropriate for it. But peer support just in and of itself, and this is more of an advocacy type of thing than anything else, is one of those things that helps benefit and support the good work that the clinicians start. Mm-hmm. And so I just wanted to throw that out there, that because my hand immediately shot up when anyone feels like their job is being taken. The role of clinicians in the controlled setting is super important. Peers are meant for after that opportunity is no longer there. So I just wanted to thank you.
I may push back a little bit on that. I wasn't offended, by the way, so thank you. But peer recovery specialists, we actually call it, we're starting a new program training, and we're calling them peer navigators for most part. And and what they are, they're the bridge between the controlled setting and the outside world. And their job is to kind of help connect them out the door, like, moving from residential into the community. But you got to start that before people leave. But what we're training is that integrated teams need to have peer recovery specialists, especially ones with lived experience, who know things and can help that integrative team know what's happening. But so I'm not totally distant, but I do think that, at least in my profession, I've heard a lot of my colleagues say, well, that's not my job. Well, then people aren't defining their roles very well. And that's part of what we teach our people in our program. What is your role? And then what are the other roles? And then respect the boundaries each other. But also the boundaries do blur at times. And that's just real. But I appreciate what you're saying. Thank you. All right, so part 2, motivational interviewing. How many got trained in motivational interviewing? How many still practice it in terms of, wait a minute, before you go on. How many still practice it by reviewing their training and practicing their training with each other, not just on clients? Okay, that second part is the challenge for us. We go I will tell you, my original motivational interviewing training was with Bill Miller in 1990. And I haven't been recerted since. I still practice it. And I have a peer supervision group that we practice it with each other. But that's one that really gets to me, is that we get certified and then we wander off and we think we're still doing it. The reality is you get trained, and the further away you get from your training, the less you're really adhering. I'm not good at adhering to a model for a model's sake, but if you're so far from what they trained you to do, it becomes a problem because it's not it's not a good tool for you anymore. So, but it's good in terms of ambivalence. We know that. My favorite scale, I don't use 1 to 10, by the way. Use 1 to 100. For older adults, I'll use 1 to 10, but younger people, I use 1 to 100. On a scale of 1 to 10, how important is that to you? It's good for older adults, but for younger people, they just hate small scales. So I use 1 to 100. You can leverage failure. How many do I do value sorts with every client I see? Does anybody know what a value sort is? Some of you, there's some heads. Okay, there's a bunch of heads. Okay, more heads. I send home a pack of value sort cards with every one of my clients after the first session. And then we spend a session talking about that. And then we spend a session talking about, okay, given those your values, that's your north. That's your true north. What are your goals? At the end of this, what is your goal? What do you want to be like? What do you want things to be like for you? Problem-solving therapy. Again, I was trained in that a long time ago. It's effective for depression and chronic illness, grief and loss. I never see this in a lot of training. How many of you have taken grief therapy courses? A bunch of you, good. More of you should take it. Seriously, I just suggesting. I'm not about telling you, but I'm suggesting, because grief therapy, a lot of older adults have a lot of regrets, especially about their drug use, but a lot of us do it. I think all of us do grief therapy on ourselves just for practice. But there's a lot of grief. There's a lot of bereavement. How many of our clients who are older have lost close friends? I know when my mother was in memory care, one of the biggest issues is she didn't have a lot. She was 92 when she died. By the time she died, she had like 2 of her close friends left. And they were both in memory care, so although once in a while we just drive by and say hi. But that issue, without addressing bereavement, that's a big risk factor in going back. Group interventions. Again, get into the around the category or the population you're doing, but it does counter isolation and it builds social support. I have no problem with group interventions building social support, not just in treatment, but outside of the program. I used to work for a pulmonary doc, helping him with clients who had smoked really bad. First thing I was training him, okay, you got to talk to them about the patch. The patch is not supposed to be taken off so you can have a cigarette. And you wonder why they end up in the ER for nicotine overdose. Here's what you do. You say, listen, I want you to put this on, and you can't smoke. And you can't just take it off and smoke and then put it back on. You're going to end up in the ER. So as part of that was me training them. And I used to work at NIDA, so I knew some of the trials. The best thing I did, though, with the patients he referred to me, he worked in Leisure World. Does anybody have a Leisure World down here? These are 55 and older community. I ran some small groups, but we did things. We had them start talking with each other, and they start setting up social things like going out to dinner together. One of them was a wonderful painter, and they said, well, why don't you go teach a painting class? They started teaching a painting class. So the group interventions are really around social isolation and what they could do to fill their time if they weren't drinking or smoking. I had some pretty good success. I was only doing it for a year, but it is helpful. So I do not think group interventions are great in treatment, but you don't have to be in a controlled setting to make these useful. Now, also, I want to say, if you have questions, again, don't call me in the middle of the night, but you can send me an email. And I will respond. I may not be in the next 24 hours because I have a grant I'm putting in tomorrow, so I'm not going to talk to people. So has anybody ever heard about Recovery Capital? Okay, good many of you. It should be something we all know a lot more about, and it fits a lot. It basically is the sum of the resources that support a sustained recovery, and whatever that is. It includes social, physical, human, and cultural capital. Sound a little bit like dealing with social determinants of health, I hope. So some of the examples of that, supportive family caregivers. We know that a lot of our older people don't have a lot of family around or caregivers around. So we need to find ways to supplement that. Stable housing. They may have a house, but they may be right on the edge of leaving because rent go up. Financial security. You're an older adult, you're not working. That's not necessarily an issue that you're not taking care of. Community engagement. I just talked a little bit about that. The biggest problem with I believe, addiction, whatever your drug of choice or drugs of choice is, primarily creates a disease of isolation and disconnection. That's my philosophy. and that's why I've been building this in my own practice. Access to health care. Again, you may have a right to get certain health care, but if it takes you 2 or 3 buses and you don't have a car, you're not going to go if you don't have somebody who can drive you. We have this wonderful program up near where I live called Villages of Kensington. And people are volunteering and they take people to medical appointments. They take people to social engagement. It costs $100 a year. Now we're trying to find some funding for people who can't afford it, but they take people around and they're trained to deal with what's going on in the back seat. So older adults face depleted recovery due to isolation, fixed income, mobility challenges, and stigma. So if we can strengthen that by improving engagement, it improves engagement and improves treatment outcomes and improves long-term well-being. Again, you could be abstinent but still have a shitty quality of life. That's a clinical term. It's in the back of the DSM. I think it's an F code. Could be an I code, I don't know. So, but really, I mean, how many of our patients are just struggling because they may not be using, and it doesn't matter what age, but their quality of life still isn't that fine. So this is really, to me, we need to be thinking this more and more about the capital, about the resources, because these people do have strengths. You were talking about meaning back there. Meaning is a strength. If you can hook up and get them to use their own background to help other people, that's great. So in recovery, what we teach at Catholic is that recovery, capital, integrative care go together. You talk about social support and caregiver engagement. It means sometimes finding caregivers. You talk about, sometimes it's just reconnecting them with their family. Access to healthcare and behavioral healthcare. Housing and financial stability, transportation and community access. Like I said, Kensington Villages, I got it from my own friend who was on dialysis and couldn't drive anymore. And I couldn't drive him every week. That really helped him a lot. The other thing that we tend to not pay attention to is the wealth of faith-based organizations in our community. I work with them so often. Matter of fact, that we're going to give we have a whole class now devoted to working with faith-based organizations. And they do so many things, and they can help with so many things, especially with our older populations. And then this interprofessional, integrated, or team-based care. And again, what we're trying to teach at Catholic is that team-based care is, everybody brings something important to the table. I was telling Diana, I spent about 20 years in the public health service. 20 years I was an active duty frontline disaster responder, and we managed a lot of disasters. As a matter of fact, I've been to Orlando many times. You guys have a lot of hurricanes down here, by the way. I did the 4 hurricanes right before Katrina, and it was an amazing. I work with the Red Cross. They're an amazing group of people, but there tended to be, when we were in some of the medical meetings, it got run like a doc shop, and nothing against MDs, but it got run where they just focused on what's the symptom and what's the issue of the day instead of what are the issues that are getting in our way today. So that's something that we try to train our graduates, fellows, that interprofessional teams means everybody has a voice at the table, everybody, and they have to respect that. And sometimes putting aside your ego to understand that just because somebody sees something different doesn't mean it can't add. I'm past. Oh, I got to get over. Sorry, guys. Harm reduction, naloxone distribution, safe medication, service. I'm going to do this really quick, and I apologize. So few senior-specific programs, limited integrations of geriatrics, and underuse of MODs and thing. So some of the training needed, there needs to be more training on prescribing safety, integrative teamwork, screening, naloxone, family education, ESPERT. The focus should be on screening and referral to treatment, because brief intervention tends to go into 24 to 48 sessions, which is not brief intervention. Building recovery capital, interventions that focus on social determinants of health, For students, we're teaching them teamwork, stigma reduction. And then agencies need to think about protocols for working with elderly, workforce cross-training, embed interventions that mitigate the impact of social determinants of health. We don't have research enough. We don't have clinical trials that include seniors, and we have insufficient funding for integrative models. Substance use is increasing and urgent. Medication first, integrative values, building recovery capital, and addressing SOH. Expand cross-training. Look, I'll just give those slides. Listen, I want to thank you for having me here. I want to thank you all for participating and letting me natter at you. Again, if you have questions, please feel free to email me. Diana has my contact information, and I'm going to be around for most of the rest of the day. I hope you have a wonderful forum, and I'll be around drinking more coffee so I can make it back to DC tonight. Anyway, thank you so much.